Do you mean to start over?
No, you
Nope,
could.
you're good.
You're good.
All right, so here are the learning objectives for the talk today. So we'll talk a little bit about the HIV epidemiology, risk for HIV acquisition, as well as PrEP indications for adolescents and young adults. Talk about some of the access barriers for PrEP and other sexual health services for adolescents and young adults. And then really try to illustrate some strategies that we've used here to remove some of those barriers and increase PrEP engagement for at-risk youth. So just to start, in 2018, there were nearly 38,000 new diagnoses in the US. 21% of these were among adolescents and young adults aged 13 to 24. The majority of these cases in youth were among young men who have sex with men, as you can see here from this table or this chart. And while Blacks are only 13% of the population, the majority or 51% of new diagnoses among young MSM were among Black adolescent and young adult men who have sex with men. So public health surveillance has only recently begun to collect HIV epi data on transgender persons uniformly, but we can see that there are also relatively high rates of HIV among transgender persons, primarily transgender women who have sex with men, in this 13 to 24 and 25 to 34 age group. So there are sort of our adolescent and young adult population. So there's also significant racial disparities for this population as well, with the highest rates being among Black and Hispanic and Latinx populations. So just sort of setting up the risk for youth, but also the racial and ethnic disparities and the particular risk for sexual and gender minority youth. Slide you've already seen. So PrEP, we know, is a great tool that can be used to reduce some of this risk for acquisition. And just as a brief 101, we know that PrEP is pre-exposure prophylaxis. It's currently approved in the form of a daily pill for HIV negative persons for prevention of acquisition. It was initially approved for adults, but an adolescent indication in May 2018 extends that approval to persons over 35, so roughly 77 pounds. There's 2 formulations currently on the market and currently approved. Both of them are single pills that include a fixed dose combination of 2 medications that you can see here. The first is emtricitabine combined with TDF, shorthand is TDF. The brand name is Truvada, which is pictured here in the top left picture. And then the second is a fixed dose combination of emtricitabine and tenofovir alafenamide fumarate, or FTAF, trade name Descovy. The second medication is approved for individuals engaging in receptive or insertive anal sex, and initial studies were not completed with individuals at risk for transmission through vaginal sex, so the FDA indication does not currently include that population. We know that PrEP reduces the risk of HIV acquisition by 99% if used as prescribed. So I actually wanted to use a case to sort of illustrate a couple of important points that we'll be going through today. This is a case that is really a combination of different patients we've seen, but I think really highlights some of the problems and some of the risks and some of the barriers to care and access and engagement that are illustrated in this population. So this is a case of Makai. Makai is a 17-year-old cis male who presents to your clinic with his best friend, Kyle, who's actually living with HIV and is a patient in the clinic, in your clinic. Makai has never been tested for HIV before, but he heard about your clinic from Kyle and wants to get tested. His rapid HIV test is non-reactive, but he screens positive for rectal gonorrhea. He does have a pediatrician that he sees regularly, but usually sees him with his mother and hasn't really talked openly with his pediatrician about sex because his mom is usually in the room with him. Makai is actually not sure about his sexual identity, but has had sex with a couple of girls from school, primarily vaginal sex, and a few often older boys he's met online, and he's engaged in receptive and insertive anal and oral sex with those partners. He used condoms with his 2 female partners to prevent pregnancy and to prevent STIs, and initially used condoms with his male partners, but has been less consistent with guys he's gotten to know because he thinks they're low risk. Because he knows them, he feels like they're not as high as risk as some people that he may have just met. He also sometimes smokes weed with his partners and doesn't always think about using condoms in the moment. His mom does know about that he's sexually active, but doesn't know he has sex with boys, and he's not ready to tell her. He wants to keep his visits with you confidential. So a couple of things are highlighted here. The first I'd like to talk about are really the PrEP indications, or the things that he's at risk for, which would make him a great candidate for PrEP. So in this next slide, we can see the table that the CDC guidelines exhibits that shows the PrEP eligibility based on risk eligibility, as well as some clinical eligibility that are summarized there. The guidelines for assessing risk are based on HIV risk categories. So men who have sex with men and heterosexually active men and women and persons who inject drugs. The injection drug use is not indicated for adolescents, for minor adolescents at this point. PrEP is not indicated for minors, but we'll talk a little bit about those two other risk categories. So Mackay is male and it's now approved for minors, so you can be an adolescent as well. He does not have established HIV infection, and he's had male partners in the past 6 months. He's not in a monogamous partnership with a recently tested negative man, so he kind of fits that criteria. And then he has there's at least one of the following criteria that the CDC recommends. So any anal sex without condoms, which Mackay fits that criteria, bacterial STI, particularly syphilis, gonorrhea, or chlamydia, rectal STI in particular puts him at risk, and is in an ongoing sexual relationship with a person living with HIV. Mackay doesn't know whether he's in a risk relationship or relationship with someone living with HIV, but he perhaps is engaged with people who have unknown status. And then there are the indications for heterosexually active men and women also includes adolescents or those minors that are over 35 kilograms. It's very similar in terms of the criteria: without acute or established HIV infection, any sex with the opposite sex partner, not in a monogamous partnership with a recently tested negative partner, and then at least one of the following. So as a man who also has sex with both women and men, which will be the case for Mackay, and frequently uses condoms during sex with one or more partners of unknown status. Mackay infrequently uses condoms, his ongoing sexual relationship with a person living with HIV, or has a bacterial STI. So both in his heterosexually active sexual behavior and his same-sex behavior, Mackay would meet the criteria for PrEP as a strategy for reducing his HIV acquisition. But there's also some factors that are really unique to adolescents that increase their vulnerability for HIV and for STIs as well. They can be roughly divided into biological, cognitive, behavioral, and social or structural factors. These factors aren't necessarily discrete or mutually exclusive, but it's really a good way of sort of organizing some of the vulnerabilities that they face. So let's apply this to Mackay. So we see with Mackay that he's had some biological risk factors for HIV, including the increased susceptibility of rectal mucosa to HIV for those who are engaging in receptive anal sex. He also has increased risk due to cofactors of sexually transmitted infections like gonorrhea, which increases the likelihood of HIV transmission in the presence of that infection. He also has perceptions of his risk, which were not aligned with his actual risk, which is not uncommon in adolescents. In this case, it was likely also attributed to his low risk perceptions of his potential partners and maybe not having the greatest knowledge and awareness of HIV prevalence in his community. There are also several specific risk factors that Mackay was engaging in that increases his vulnerabilities. He's had multiple sequential partners. He's also had inconsistent condom or barrier use. He has, and he's engaging in sexual activity in the context of intoxication with marijuana. So we often think of adolescent risk taking as deficits or maladaptive, and in this context, they arguably are deficits. But we also know that risk taking is a normal part of adolescence development and really aids youth in their ability to develop their own identity, allows them to try out for new things and figure out new things about themselves, which is an important component of adolescence. So I don't want to sort of put risk and it's sort of always in this bad category. It can be really productive for adolescents, but we also should recognize when they are not productive and can place them in increased risk for poor health outcomes like HIV. So Mackay also has some social and structural factors that influence his risk. So sexual networks, particularly in areas with high HIV prevalence, in online sexual networks, in certain racial and ethnic groups, we know there's higher prevalence of HIV and untreated STIs because of a number of different factors, which I have a whole different talk on, but not specifically because or intrinsic to the individuals in those communities, but because of the structural factors that create that. So we know that that increases his risk as well. And then finally, he has low parental monitoring because his mom doesn't know about his sexual behavior. He can't provide guidance around that. And also has lots of deficits in terms of his access to care, lots of missed opportunities with his pediatrician in terms of providing him with information, with testing, with PrEP or other prevention tools, because of that opportunity to have conversations about his sex, his sexuality and sexual behavior did not happen and did not occur. So let's talk a little bit more about PrEP. I've pointed out some of the risk factors, and PrEP, as I said, is a great tool, but there are lots of barriers for PrEP in terms of adolescents and their access to it, and their ability to engage in PrEP care. So youth are about less than 10% of PrEP prescriptions, but more than 20% of the new HIV infections. So there's definitely a disconnect there. And some of the barriers include the impact of minor consent laws. Can minors actually consent for PrEP or not? And we'll talk a little bit about that. Concerns for confidentiality, which I've raised or alluded to in Makai's case. Limited access to testing, HIV testing services. Lack of access to inclusive, comprehensive sexual and reproductive health services, as we saw with Makai. And then once youth are engaged with PrEP, we know that there's lots of challenges with maintaining daily adherence to medication for prevention. So let's break down some of these a little bit further. So minor consent. We know that no jurisdiction, actually, of the 50 states in DC prohibit minors from accessing PrEP or other HIV prevention services without parental consent, but actually only 3 jurisdictions explicitly allow minors to consent for prevention services. That's Connecticut, Iowa, and Maryland. Maryland actually happened just a few years ago through some advocacy of the Maryland AAP, Chase Brexton, some providers on this call to really provide specific language around adolescents being able to consent for PrEP. And I'll touch on the statute in the next slide. About 13 jurisdictions explicitly allow minors to consent for STI prevention. And all jurisdictions allow minors to consent for testing and treatment, although there's some caveats there. So there's definitely some consent issues that can impact care. Fortunately, as I said, in Maryland, the statute was updated to include the language in bold, which specifically explicitly stated that adolescents can
Marinas, I think Errol's got muted. Errol, you're
Yes,
muted.
I'm trying to unmute him right now. There he is.
Cool.
I think she was trying to mute other lines that were not muted.
Yeah.
So if you're not muted, please mute because there's some background noise. Thanks.
I don't know if we missed this, but I was indicating that youth are less likely to access sexual and reproductive health services if it's unclear if confidentiality will be maintained. Most jurisdictions do ensure confidentiality for youth who can legally consent for those services, but there's lots of sort of caveats and barriers to that, especially around those who are dependent on a parent's private insurance who might receive explanation of benefits indicating that certain services were provided. We've had our navigators and folks that work with our youth to sort of help navigate that process, but it's still a potential barrier. There's a quote here that really explains the problem with this and the problem potentially with providers not establishing confidentiality ahead of time and creating a space for youth to be able to talk about their sexual health needs. This young person says, this physician asked me if I was having sex, and because my mom was in the room, I told them no. I think my mom wasn't there. It wasn't there. I would have told him the truth, and I think it would have been better if they had asked her to step out of the room. Another quote from the same study, a youth says, I just think doctors need to ask more questions. So it's certainly, this is a study of sexual minority adolescents and their experiences with healthcare providers, and I think that's a message that's really important for folks to come away with. And then HIV testing, we saw that that's a barrier. So HIV testing in youth, we know that 44% of AYA living with HIV are unaware of their status. In 2017 Youth Risk Behavior Survey, which is a survey of high school students, so the 9% of high school students were tested. Fortunately, among male students who have sex with men, about 15% were tested, so higher, but still insufficient for sexually active youth, and also for, given the guidelines that suggest everyone age 13 and over should at least have one HIV test regardless of their sexual behavior. We know that young Black MSM who are at higher risk for HIV, they do have higher testing rates than some of their racial ethnic peers in other subgroups, but they have higher rates of unrecognized infection. So it's not really doing their job in targeting and prioritizing those groups that need to be tested. And barriers to testing include things like we've talked about before in Makai's case, so low risk perceptions and knowledge of HIV risk, low perceived risk, stigma around HIV, confidentiality, limited sexual health discussions with providers, and access to services. And that leads me to the next barrier, which is the lack or limited access to inclusive, comprehensive, and confidential sexual and reproductive health services. So a discussion of sex and sexuality are often limited in adolescent annual health visits. That's been, I'm sure, magnified by the context that we're currently in, when we have less time with patients and less opportunities to engage because of COVID-19 mitigations. So a lot of these anticipatory guidance around sexual health also going out the window in some cases. Pediatric providers also have limited knowledge and awareness of PrEP. That's certainly improving. There's been lots of sort of work around increasing that awareness and the knowledge, but it's still low compared to our adult colleagues. And then LGBTQ youth or sexual youth are often marginalized in healthcare spaces by a non-inclusive setting, and non-inclusive means not only not seeing representations of themselves in documentations and forms and pictures on the wall, but providers are also less comfortable with taking the sexual history of sexual and gender minority patients, and often have inadequate training to elicit disclosure of sexual or gender identity, or to talk about same-sex behavior, or to talk about risk behavior or sexual behavior in general. So those are some of the barriers, and there's a lot of barriers. There's lots of adolescent and young adult vulnerabilities and disparities, especially for sexual and gender minority youth and racial and ethnic youth. But
Chicken Little! What is it? What's going on?
The sky is falling! The sky is falling!
The sky is falling?
Are you crazy?
so no, the sky's not falling. We actually know there are multiple challenges and barriers, but also multiple opportunities for intervention. And so I'd like to spend the next few slides talking about some of the strategies that one can do in a clinical setting, and also some of the work that we've done in our setting to improve access and reduce some of these barriers before COVID, during COVID, and beyond. So just as a reminder, again, I don't think you all need convincing, but in case you do, there is some data from 2017 YRBS survey, again, indicating that pediatricians do need to talk about sex because youth are having sex. We know that sexual debut and sexual experience and sexual activity increases with age in high school, with by 12th grade or 17 or 18, about 57% of youth having engaged in sexual activity. And you can see the total sort of overall percentage is about 40%, with specific ranges by race, ethnicity, and sexual identity. So it's really important to be able to do that and be able to ask about sex and take a comprehensive and inclusive sexual history. And so some bullet points here to kind of guide folks in that activity. Again, establishing and ensuring confidentiality is really important. Engaging youth in other aspects of their lives before jumping into questions about sex, drugs, and well, maybe sex, drugs, and trap music, or something along those lines. Of rock and roll maybe is not relevant, but important to sort of develop rapport before sort of jumping to questions, which I know is hard, especially with limited time, but it's important to sort of develop a relationship with you so they trust you and feel like they can open up to you and ask questions that they might have. As a part of that, it's important to be comfortable asking sensitive questions, or at least pretend that you're comfortable. They prefer that you're direct and have strategies for putting them at ease. Oftentimes we say, we know this is embarrassing or this is awkward to talk about, but this is something I talk about with all my patients, not because I want to get in your business, but because I want to make sure that you are safe and I can help you be safe in the activities you're engaging in. And also important to know that how a person identifies their sexuality or gender does not always tell you who they have sex with, and important not to make any assumptions, be very specific when asking about sexual behavior. All these things are really important aspects of understanding adolescents' risks so that we can properly provide resources to help alleviate those risks, like PrEP. It's really important that you check your body language and facial expressions, and not to make any of the facial expressions like you see here when you hear what the type of activities you might be engaging in. Beware there are a wide range of sexual behaviors, activities, and expressions. Try to remain open and neutral and informative. And I just saw a patient who asked me about cock rings and what those are for and how people use them. And so we had a nice conversation about that. Very straightforward conversation without me sort of making any of these faces. So I think it's important to be able to do that well. Provide comprehensive and non-stigmatizing information about sexual and reproductive health. That prompted me to ask questions about that particular question from that patient, prompted me to make sure that he was not having concerns about his ability to maintain erections, because that's what some people use cock rings for, and sort of allow to kind of dive deeper into other questions, but also provide him with important information that he might need. And then it's important to promote healthy sexuality, even if a teen is not sexually active or not currently sexually active, especially for adolescents. It's really important where sex may very well be sporadic or intermittent, or they might not be having sex like that. It's a quote that I hear a lot, but still it's important for people to know how to be safe once they do start engaging or re-engaging in sexual relationships. So I think it's also important really to integrate sexuality education into the practice of caring for youth. We don't know whether they're getting it at school. They're probably not getting it at school right now. And so it's important to really perform that function as a provider as well. It's important to make sure folks are aware of the sexual behaviors that are associated with HIV or STI acquisition. And really, I think PrEP is a tool that we have, along with other tools and other prevention and risk reduction strategies that we should make patients aware of, including abstinence, condoms, and other barriers, fewer partners, being comfortable with communicating with partners, obviously HIV and STI testing, and then PrEP is a component of that. It's also helpful to provide access to in addition to access to PrEP, but access to barrier methods in clinic, incorporate effective interactive counseling approaches like motivational interviewing, and finally, really providing education materials that are inclusive with regard to race, language, gender identity, and sexual identity. And then there are just some really, some strategies you can also use that we've
Errol.
Is he frozen?
I think he's frozen.
Beauty of Zoom. Yeah, I think he's frozen for a second. Okay. Let's see if he'll walk back in. Let me just shoot him a quick text. The rain.
It's the challenge with Zoom.
Exactly. Hopefully he logs right back in.
Yes, definitely. Yeah, he's logged off, so he's coming back in. But hopefully, people, I saw a question about if he's going to address PEP. Yes, we will send the slides out as a PDF at the end, and we think we also have been able to send recordings of the talks. And certainly, we do want to hear if there are other talks and things that you want to hear as well. Definitely. I'm not sure how much he's going to talk about post-exposure prophylaxis, but certainly we can talk about in the after the presentation. All right. Let's see.
And he just logged back in.
Okay, fantastic.
Sorry, for some reason my internet turned off. Let me get back to my slides.
It always happens when you need it.
All right, can everyone see?
Yes, sir.
All right. So I was saying that this is just some office and clinical strategies to remove some of the structural barriers that youth might have. Friendly office hours, making sure we post the confidentiality policy clearly in patient rooms and waiting areas. Our clinic is a Title 10 clinic, meaning we can provide confidential services outside of insurance for youth that need it. So having those types of clinics or partnering with clinics such as ours to make sure that adolescents can get confidential and free if needed sexual and reproductive health services. Integration of transportation services or assistance. One of our colleagues and fellows in our program here have a Lyft project that allows us to provide Lyft rides to patients so that they can come in for their for care. And that's really been important and useful during COVID as well, especially with youth having less access to transportation or being concerned about public transportation in the midst of a pandemic. So that's been really helpful in our clinic. So having that type of strategy to reduce transportation barriers can be important. And fast tracking some sexual reproductive health sessions with because we don't want them staying here forever, because can be a barrier to coming in if they feel like they're not going to get out of clinic. It's something we're working on a fair amount in our clinic, but I think it's important to utilize that as well. So those are just some general strategies. I wanted to spend the rest of the time talking about a few of the strategies we've used here specifically. So I want to highlight three things that we do here at our, and I didn't mention the Johns Hopkins Center for Adolescent and Mental Health is really the practice and place that I'm referring to, that I've been referring to. So I want to talk briefly about three things: cultural competency training to ensure inclusive clinical settings that myself and Dr. Arrington Sanders worked on prior to starting our gender clinic. We wanted to make sure that our space was a safe space for youth. Additionally, when we're adding that additional services, I'll talk a little bit about our PrEP program and then a new program that we're developing as well. So just briefly, as I was mentioning, we wanted to start this, have this training. This happened a few years ago before we started our clinical space. But I think it's important to start our gender services. I think it's important to highlight it because it's really important, again, that youth feel that they are safe and welcome in their medical setting. And so we need to make sure that everyone is on board with that. So we engage all members of our healthcare team. We had an institutional commitment to diversity and culturally competent care to all patients, which really supported that effort. Allowed us to have a full morning off from clinic with everyone there to participate. We included sessions on sexuality and gender, sort of one-on-one topics, and had subsequent additional sessions with requested by some of our staff, our front desk staff in particular, a sexuality and gender 102 to make sure that folks understood and were able to provide welcoming and safe services for our youth from the front of the building to from entry to exit. We talked about health and healthcare disparities that affect this youth, so folks had an understanding of why it was important that we protect these youth. And then even had some small group exercises to kind of help folks think about how they might strategize on being more inclusive. So as I mentioned, we had a variety of folks that took part, nursing, front desk staff, medical assistants, our navigators and non-medical case managers, social work. Folks came from outside of our clinic, but also within the children's setting to get access to this training. And we had HR and study and outreach workers and study coordinators, because we incorporate research in a lot of work that we do and use that to actually engage with the population as well. So lots of folks were involved. And I just want to show you a brief video that we shared during this session to sort of illustrate how we can be more inclusive with our patients. And this is actually featuring a patient from our clinic with her permission, but she's can't see her face, but it was part of her. She wanted to be a part of this. So let's make sure.
Come in.
Hi, are you Sabrina?
Yes, ma'am.
Great. I'm Kathy. I'm the adolescent nurse. Nice to meet you.
Nice to meet you too.
I have your flu shot here that I was going to give you. But before I do that, I have to verify your date of birth and your name, your legal name as it's listed in the computer. I'm sorry if that makes you uncomfortable.
That's okay. The name is Samuel Brown, and the date of birth is 10/2/1997.
That's right. Okay, great. Can I use this arm?
Yes, ma'am.
Perfect.
After Sabrina gets her flu shot, it's time for risk reduction and HIV testing. The counselor does an oral HIV test, which is negative. She discussed the importance of consistent condom use and other forms of contraception. Sabrina then sees social work about changing her name.
Yeah, so that was just an example of a longer video we showed as a really to give people an illustration of how to be inclusive in our setting. And then I also wanted to highlight our PrEP for Youth program. It's a program that was developed by Dr. Renata Anderson-Sanders in our group here, and that I co-direct along with her, along with members of our team, many of which I think are on the call, so props to them. But the PrEP for Youth program is a clinical and community-based program that really aims to increase access to PrEP, like we've been talking about, specifically for adolescents ages 15 to 24, through not only PrEP linkage, but also engagement for adolescents that we know are in a high prevalent community. And also incorporates community-based outreach, education, both in the clinic and outside the clinic and virtually as well, and access to HIV and STI testing. We, through our peer navigators and PrEP navigators that are a part of the team, we're able to provide risk assessment and reduction counseling and support to our patients that are coming in for primary care, or patients that are hear about our clinic, like Makai heard about our clinic, to really make sure that they have an understanding of their STI risk and ways in which they can reduce that risk. Make sure they have access to the other things that they need. Oftentimes there are other priorities in life that can also be barriers to accessing care, because there's other things that are really more important. So we make sure we have through our navigators, but also through our Health Community Connections program here and the clinic, can provide folks with access to the things they need, so they can actually they can take those things off their plate and really have the ability to focus on these other risks that may also impact their health. And then emotional mental health support as well. We have great social workers here and great members of our team that can help connect folks to care services, mental health care services if those things are needed as well. And then also linking and engaging folks in care. So we know that it's important that folks have comprehensive services. We know, for instance, that folks who are transgender or gender diverse really want to be able to get access to the additional care around sexual and reproductive health in a place that's gender friendly, but also in the place that's providing with their gender care. So we really try to integrate that with some of those services and really provide comprehensive services to patients. And our PrEP program has actually been a really great way of engaging folks in primary care as well, which is also going to be important for maintaining their overall health in addition to their sexual health. I talk about our peer navigators or near peer navigators. We have a frequent follow-up program because we often know that adolescents need additional support around adherence and need additional support around taking a daily medication. So text messages, reminder calls, again, the transportation support that I mentioned. It's still a big challenge to take a daily pill, and I'm really pleased to know about the things that are coming down the pike in terms of long acting injectable PrEP, which I think is going to be really, really important for this population, but they'll still need the supports that are really a part of the program that we provide. And then we have some great education and community outreach. You can see here a pamphlet that our team developed that really gives people information and education about staying healthy and being able to engage in for our sexual minority youth, particularly our male youth, to engage in being able to engage in sex and know about how to have sex safely, how to have same sex and anal sex safely, how to avoid STIs, information about prevention as well. And then we also have a website that has lots of information. We've updated it in this COVID timeframe with additional COVID-19 resources and information about not only testing, COVID testing and all those things, but how do you stay safe in a pandemic? How do you date in a pandemic? How do you sort of engage with your partners in a pandemic, and really the things that are important to do to take care of yourself and protect yourself from COVID, but also protect your sexual health. This is just some other screenshots from our website. This is a link that people can use to actually get access to us and be directed to us, so we can reach out to them to provide them with services or connect them with services. Again, education and information. We have also a blog that I think this is here where folks can, we have folks that update sort of discussions around sexual health. So really engaging youth in different spaces. And then before the pandemic, our team, led by Dr. Sanders and our navigators and community folks that are engaged with our community and leaders in our youth community, we've done a ton of sort of community outreach. And again, this is about enhancing sexual health and letting folks know about their sexual health, know about where they can get testing, and know about where they can get other services. So it's a way of sort of doing outreach by providing fun activities, engaging with our ballroom community, having really fun activities where we could gather and do things outside, but also incorporating sort of sexual health in those spaces. We also have a youth advisory board that's also led by members of our Ryan White team that really engage our youth that come to our clinic or may have come to our clinic, or their friends that know about things that are important that we should know about, and really engaging with them to get feedback on some of this programming, but also to provide them with support in their lives. So Voices for Youth is this new program that is funded by the CDC through our Baltimore City Health Department that focuses on ending the HIV epidemic pillars, specifically around diagnosis, prevention, and treatment. And our program, Voices, stands for Virtual, I'm going to get it wrong even though I came up with the title, Virtual Online Integrated Sexual Health Services for Youth. And really the idea is to use virtual community outreach, our telemedicine that's been developed as a part of the COVID pandemic, and moving some of the coaching and navigation to the virtual space to help identify or diagnose folks who need either access to care or prevention, link and retain those youth to treatment and prevention cascades. We really focus on a population that I've been talking about all along that are higher risk, sort of adolescent and young adult age group, gay, bisexual, other MSM, transgender women who have sex with men, and then certain zip codes we know in Baltimore are associated with increased risk and higher transmission, with a specific focus on African American MSM and transgender women who have sex with men because of the disparities I described earlier. And then this model is really focused on really engaging youth through, in the virtual space, through paid advertisements on social media and hookup apps, virtual events, which I'll highlight in just a second, and then many of our CBO partners, advertisements, both virtual and physical advertisements and postings that point people to a webpage that then has lots of resources, and then that website also points them to a peer navigator or coach to again get connected to care in a way that may be challenging now given the pandemic. So I just have some screenshots, and this is actually an old screenshot. Our Aubrey Alvarenga, one of our navigators, has really done an amazing job at updating this and making this very youth-friendly with lots of resources and information, and got feedback from our youth advisory board to really highlight this and make it pop and make it relevant for youth. But the purpose of the website is to highlight the virtual services, including home testing, providing some virtual navigation and coaching around getting access to those home testing kits and getting access to sexual health services, either online or through in-person services, highlighting some of the community events and outreach that we're doing, and then again, having a form that we can, an intake form that really people can indicate who they are, what they need, and how we can help them. And I mentioned that there are some virtual, we moved some of our community outreach to virtual spaces. This is an example of an event that was held that really provided folks with information, but also kind of a hangout spot, a way to kind of engage folks and things that they want to talk about, but also provided information. I've left one of our navigators. Everyone else is blocked out, but this is one of our navigators who really provided information through sort of like a commercial break about the resources we have in our clinic and in our space, so that folks could to know more about that information. And the navigators in this program will really work with youth to identify their sexual health needs and connect them to at-home HIV and STI testing if appropriate. We're partnered with I Want the Kit, which is a program through Johns Hopkins, which in the health department, which provides home test kits for HIV and gonorrhea, chlamydia, trichomonas, I believe, as well. The goal here is to provide, once youth get access to the kit, we help them get access to the kit, it comes to their house, and then we provide a telemedicine visit, or we'll provide a telemedicine visit, it's still under development, to provide pre and post-test counseling virtually at the time of the test, to really walk people through it, really prepare them for the test before they do it. We know that there's home test kits that are in the store, and that's a great way of increasing access, but this will allow us to actually provide them support at the same time that we're increasing access. And we have the opportunity to also link people to PrEP or to care based on the results of that test through our comprehensive services in our clinical space. And then the navigators will continue to follow youth who virtually who are connected to either treatment or prevention cascades, to provide them with adherence support, other support, resources, et cetera. And these peer navigators are really trained in health coaching that combines one-on-one coaching with navigation based on some work that Dr. Sanders has done in utilizing that technique to provide support to sexual and gender minority youth. It includes supportive services, adherence counseling, and tailored support for care engagement. So in closing, we know that adolescents and young adults' risk for HIV is affected by developmental factors, community factors, and structural factors, as well as limitations in their sexual and reproductive health services and access to those services. All of those things have been made worse and exacerbated by the COVID-19 pandemic and some of the mitigation strategies around it. And PrEP is a potential tool that we can use for reducing risks. There are lots of barriers, but there's lots of opportunities, as I just described, to really intervene and reduce some of those barriers and really increase engagement. So I'm hoping that some of these things that we've discussed have provided folks with food for thought, and I'm happy to answer any questions.
Awesome. Thank you so much, Errol. That was fantastic. It's always, though I see you all the time, it's always nice to really hear what's happening. There are a few questions in the chat that maybe we should go to quickly. Someone asked earlier about PEP, and can you talk a little bit about how you address PEP within the programs in providing PrEP and then addressing PEP? Maybe you can go to that.
Yeah, so so certainly, PEP is also another important prevention tool for those folks who've been exposed to or potentially exposed to HIV within the past 72 hours. So we, as a part of our risk reduction strategy and a part of our HIV STI testing and counseling, we're doing great sexual health, sexual history taking to understand recent sexual activity, and we've made our services known throughout our hospital system within the Children's Center. So we not only have the ability to sort of make sure that we are asking about that when we're seeing patients in our clinical space, but also if patients are being seen in the emergency room or being seen in other parts of the hospital, or the frontline folks in our setting, the residents know about the services we provide. So we have a consult service in adolescent medicine, so we can engage with those youth immediately and quickly to make sure that we can assess their risk for recent exposure and give them access to the NPEP medications, follow them in our clinic, and then transition them to PrEP services once they've completed that NPEP medication and have tested negative, if that's what they choose to do. So there's definitely a component of our care that we provide as well.
And just to make sure, in case people don't know, PEP or NPEP is non-occupational post-exposure prophylaxis, so different from pre-exposure prophylaxis. There was a couple questions about training and how counselors and whether or not the navigators have specific HIV counseling testing training, and then how can people get additional training, youth-specific training for their counselors? Answer both.
Yeah, so they definitely, they do have specific HIV testing and counseling training that many of them received as part of the City Health Department's IMPACT program, which occurred a couple of years ago and really placed navigators throughout several of the sites in the city. So they have training through the Maryland State has an HIV testing and counseling training, which they had access to and get updates on. The other question was about youth-specific training, I believe.
Exactly.
Yeah. So the coaching service, the coaching program that I mentioned before that Dr. Sanders runs as part of our program, we are using that in particular to provide particular coaching around how to engage with folks who are at risk, but also youth in particular. There are a couple of, I think it's really important also to kind of make use of some of the other resources that are sort of available online and other spaces. There's lots of great resources around how to engage with youth in particular in clinical settings through American Academy of Pediatrics. The CDC has some, has particular information specifically around HIV and sexual and reproductive health. The Society for Adolescent Health and Medicine also has some of those resources on their webpage. So those are things that we really point people to as well. And then a number of us do things like we're doing today, which is sort of providing some of that training and some of that information about how to, what are the things that we need to do differently to make sure that youth are supported in a way that might be different from adults. So utilizing sort of, many of us do that type of teaching as well and share those resources sort of in person or virtually, in addition to some of the online resources I mentioned.
Are there other questions? There's a lot of kudos and great presentation, informative, et cetera, and it's been a very engaged audience. Are there any questions that were not put in the chat? Any comments? I think one of the things and one of the reasons we really wanted to do this today is I think certainly one of the first things is recognize that youth may need a little bit of a different lens, right? And so sometimes a training that may cover everybody may not necessarily cover youth. And, Dr. Bill's talked about certain resources that are available, even how to assess sexuality, the laws. That's a question we oftentimes get. Well, how do you get a parent out of the room if they won't get out of the room? It's important to realize that you probably need to get the parent out of the room to really get an honest discussion. How to address sensitive issues when you don't feel comfortable yourself, right? But really important to open that. So it's really great to hear that. There's a question in the chat. So who should we, go ahead, Errol, sorry.
No, I was just gonna say one of the other sites that I forgot to mention was a Physician for Reproductive Rights, or Physician for Human Rights, or Physician for Reproductive Health, sorry, PRH. They have great videos of cases of different interactions between physicians and other providers and patients. Like great modeling of sort of how to talk to you. And just to put a plug, I just completed developing an STI module for engaging with adolescent males, and there's several other authors that did similar sort of adolescent sexual health services that are sort of set up as cartoons and animations, but kind of give lots of great information, again, about how to engage with youth around these different issues. And that'll be published on the SAM website, I think, within the next few months. Society for Adolescent Health and Medicine.
I think they're just also thinking about SIECUS, S-I-E-C-U-S. And I forget what the acronym stands for, and as well, Advocates for Youth is another organization that does a lot of really cool stuff. So we will share the presentation, and if you want to add some of those resources at the end, Errol, that would be very helpful. There's a question in the chat about who should we contact for more information and possibly support for our organization, or to send referrals. Certainly you can reach out to Maria Terraforti, who coordinated this, and we can help direct where to go for more additional questions. In terms of referrals, I think certainly our PrEP program, we have PrEP. There are also some of the other individuals on the call who also provide PrEP for youth. Part of what we want to really encourage you, though, however, is that PrEP doesn't have to be done by specialty centers. All of you can provide PrEP, really. And there's an effort to try to decentralize PrEP so it's not just a referral. Every referral sometimes can be a missed opportunity when that adolescent gets the nerve up to ask about PrEP, and then you say, well, now I'm going to send you to that next place. You may lose them in the continuum of care. So getting us all comfortable to to provide PrEP or help pick up the bat phone and call Dr. Fields or myself to help guide you through it. But certainly we're happy to accept referrals and support.
Good.
But yes, you can email Marinas. Marinas, can you put your email in the chat so then people can have that to reach out to you? You're talking on mute.
I'm going to add my email address as well as the Part D referral address.
Awesome. This has been fantastic. Recognizing the hour, we're almost there. If there are no additional questions, we will close. Thank you so much for your time and attention. Please, please, please feel free to, not feel free, we do want you to give us feedback. So you'll get a survey, please give us feedback, and especially if there are other things that you want to hear. We have a big network, like I mentioned, several of the organizations that are working with us at Part D, but we also, again, want to highlight you. So if you think you have something that you want to share, by all means, Part D is happy to highlight you and to engage and amplify all that we're doing. All right, with that, be safe, enjoy the needed rain, and we'll see you next time. And next month will be psychiatric issues and related to HIV, et cetera, by Dr. Prince. Thank you, everybody.